And the surface area is very important for air exchange. The less surface area you have, the less air exchange you're going to perform. Okay? That's emphysema. And then a milder one, which is bronchiectasis, right? So these are going to be your obstructive lung disease. Okay? Now I want you to think and compare and contrast what we just said as a review. Breathing in is not a problem, breathing out is a problem. That's obstructive. Now look at this. You have a patient who is not able to fill their lungs to start with. So they are not able to breathe in. They have difficulty breathing in. So there is something restricting the lungs from expanding. Okay? So the lungs are not expanding fully. They are not open out. Okay? If you have a bottle and you want to fill it and it's closed or it's not open out or congested, right? Or you are pressing on and there's pressure from the outside, or it's not relaxing for you to fill it, you won't be able to fill it. Make sense? So the same thing here. If there is something preventing the lungs themselves from opening out and letting the air in, that's going to be a disease of the lungs, of the parenchyma. Okay? Basically, when I say the parenchyma, it's the tissue that makes up the lungs, right? The flesh, basically, right? That makes up the lungs. Okay? Or it could be there's nothing wrong with the lungs. The lungs are fine. However, there is deformity on the thoracic cage. Because in order for you to breathe, you need for the thoracic cage to expand. Right? So we have external, remember in neuroanatomy, we talk about external intercostal muscles. And these external intercostal, what they do, they pull the thoracic cage to the outside. And every time you breathe, it's a blessing that if you're able to breathe fine, right? Because there are hundreds of thousands of people out there are not able to breathe. So this, which is very simple action, expanding the cage to the outside, making the ribs pull to the outside, sometimes, in some cases, it's not done, right? It's not performed. Why? Because something affecting the muscle, the external intercostal muscles, or there is deformity to the thoracic cage itself. Make sense? So anything that affecting the muscles, right, or the innervation of the muscles, or somebody has a deformity, right? So when I had either congenital or acquired, I have a car accident or something, and then they ended up with the deformity of the thoracic cage. Make sense? Or the vertebral column, right? For example, scoliosis, lordosis, kyphosis, any of these deformities to the posterior aspect of the thoracic cage also is going to prevent the cage from expanding up. Okay? So these are the only two conditions, either something external or something internal. And that's why the classification of the restrictive lung diseases are going to be either something affecting the lungs themselves or something affecting the thoracic cage. Make sense? Or the innervation of the thoracic cage, right? Or any of the muscles. Any of the muscle that, what is the main muscle that for breathing? The main muscle of breathing, diaphragm. And the diaphragm gets its nerve supply from phrenic nerve. Phrenic nerve, very important. Remember, it's a diaphragm. The main muscle for respiration is going to be the diaphragm. The diaphragm receives its nerve supply from the phrenic nerve. Remember this, the rest of your life, you're going to need it. And the phrenic nerve gets its root from, no, it's okay, C3, C4, and C5. Cervical vertebrae 3, cervical vertebrae 4, cervical vertebrae 5. C3, C4, and C5 keeps you alive. Or the diaphragm for that matter, right? Either way. So just remember this, it's important. Because if you have a car accident, or like I told you a story about Christopher Reeve, right? Superman. Yeah. He fell from a horse to play with whatever that type of sport. He severed C3 and C4 and ended up not able to breathe. He died from pneumonia. Because remember again, if you are not able to ventilate the lungs, you will have tremendous amount of accumulation of bacterial infection or whatever, and that's what's going to kill you. Or if you die immediately, then if you have full paralysis, then yeah, that's. But if you survive the accident itself later on because you don't have ventilation, you're gonna have other issues anyway. But remember, either parenchyma or outside, right? Now there is another set. There is another set of conditions that affect restrictive lung diseases, and we call them collectively. Somebody read ahead of me. IPL, idiopathic pulmonary diseases, or idiopathic lung diseases, ILD, right? So now when I say idiopathic, something is happening, but we are not able to pinpoint. So it's not known. We don't know what's causing it, okay? All right? So that's going to be the set of diseases that consider idiopathic, okay? Now you should ask me the question, right? What happens to those who have something with the lungs? Why their lungs are not able to expand? More than likely, these are what? A group of diseases called, nobody reads, pneumoconiosis. Pneumoconiosis. A group of diseases collectively known as pneumoconiosis. Now, it includes people who are breathing in an environment or occupational environment where they are exposed to harmful substances. Like what? Like coal miners, right? Like shipbuilders, right? So somebody exposed to asbestosis, right? Now asbestos causes asbestosis, right? So basically, you are inhaling an environmental agent that causing, it's not cigarette smoking now. We're talking about these chemicals, these are coal or silica or other dust, right? Or some people actually also work in the farms, right? Because they have tremendous amount of bird droppings, right? So and they're breathing those chemicals all day long, okay? Lead, yeah, to some extent, yeah, because lead currently, we did well actually in the United States since unless something before the 70s, but lead is being completely eliminated from paint, from gasoline, from other environment, because it could harm. But more than likely, people who are affected by this are going to be the one that I'm listed in your chapter, are going to be the coal miner, people who work with sand or any kind of dust. As a result, what's going to happen? Their immune system actually. Remember, in the lungs, we have a type of cells. Those are the ones that are part of the immune system, right? And they call them dust, actually, dust cells, right? So these are the ones that macrophages are going to eat on these chemicals, trying to prevent their expansion and all that. But as a result, you are causing inflammation. That inflammation eventually causing fibrosis. So you end up having a lung that is not elastic enough to expand. You lose the elasticity. Make sense? And as a result, they have fibrosis. So fibrotic lungs are not able to fill with air because they don't have the ability or the elasticity to expand and recoil. Make sense? So they're going to be the main diseases that you have them listed in the slides. Okay? But that's it in a nutshell. That's all. So the idiopathic is not that much. It's very sweet part of the chapter. And I'm just going to go over it from the slide. And then we're going to spend the entire day tomorrow going back again, reviewing and all that. Okay? And this is it. That's a lot. This is the end of what we will talk about. Restrictive lung diseases. And all the details are in the slides. As soon as I find it. Okay, here you go. All right. All right. So in English, restrictive lung diseases. Restrictive lung diseases is a set of diseases that makes it difficult for the lungs to fully expand. Okay, reducing the amount of air to be inhaled. So that's important because when I come and talk to you about the volumes, I want you to keep in mind that what we started with a low volume because this patient is not able to inhale, so their volumes are going to be low, right? Their TLC is going to be low, right? Their vital capacity is going to be low, right? Because they are not able to fill the lungs, right? Two types, either interstitial or extrapulmonary. That's exactly what we just said. Either interstitial, meaning the parenchyma is affected, the lungs, tissues are affected. So when we talk about interstitial, we have damage to the lungs themselves, okay? The lung tissue itself being affected, okay? And these are the ones that we will talk about when we come to somebody inhaling any kind of environmental, I mean, trust me, when we say inhale stuff, if you just go for a trip to a coal mine and you're just visiting and you inhale once, it's not going to affect you. You're not going to develop restrictive lung disease. We're talking about people who are being exposed for a long time to have these effects. But nonetheless, for your classification, either you have a damage to the parenchyma of the lungs, or you can have something outside, damage to the structure around the lungs, right? So preventing the chest expansion. Keep in mind, always, in order for you to breathe, your thoracic cage has to open up, okay? If it didn't, then you won't be able to. Yeah, I'm sorry this slide is so busy, but basically it's talking about the stuff we just talked about. Interstitial or restrictive lung diseases, lung tissue damage, causes stiffness because you have fibrosis, making it harder for the air to enter during inhalation. You're not able to inhale. As a result, you're going to have a reduction in the lung volume. Okay? Now, basically, the elasticity is gone. It's telling you here the pathophysiology of this disease or this set of diseases. You have the elastin and collagen. In alveoli, it helps to expand the lungs and recoil, expand and recoil. You need this collagen and elastin to allow you for expanding, collapsing, expanding, collapsing. If it is gone, you don't have that expandability, right? So you don't have that ability. Now, these are pneumoconiosis. That's the word for you. Pneumoconiosis. Pneumoconiosis, basically, when you say pneumoconiosis, you're just saying an individual who is being exposed as a result of their occupation, okay? The one they do, like coal miners, right? So coal miners' pneumoconiosis, inhalation of the dust, the coal dust. Silicosis, inhalation of the silica dust, okay? People like mining, stone cutting, and so on. Asbestosis, so inhalation of asbestos, right? But these are construction, shipbuilding, and so on. Although asbestos is not that much used anymore, okay? And then you have sarcoidosis. Now, this sarcoidosis basically you have granulomas of the, basically it's an immune response causing it's a disease basically, right? So as a result, the immune system is calling for fibrous connective tissue. Now, hypersensitivity, pneumonitis, or inflammation of the lungs. By the way, pneumonia is basically you're talking about, or pneumonitis, inflammation of the parenchyma, of the lung itself, right? So immune reaction for particles like bird droppings or mold, leading to chronic inflammation and fibrosis. Okay? Now, diagnosis, again, we're going to rely on our famous numbers of um, the functions of the lungs. Spirometry is going to be vital, okay? So spirometry, what you're going to see on the spirometry, you're going to have a decreased TLC. Why? Because lungs are not opening up. So your total lung capacity is going to be low. Makes sense? So forced vital capacity are going to be low. Forced expiratory volume is going to be 1 second, and the normal. So now you're going to have normal. So remember, because this person has no problem breathing out, their problem is breathing in. So the ratio between the FEV1 and the FVC is going to be either normal, or it could be slightly, most of the time it's going to be normal, or it's going to be slightly increased, okay? Why? Because the amount of air in the lungs is not that much to start with. So the ratio is going to be, the ratio is going to be either normal or going to be slightly increased. While remember, for obstructive lung diseases, your landmark, the FEV1 to the FVC, is going to be reduced, going to be less than 80%, because there is an obstruction, right? Now, we also have imaging. So imaging is going to show like glass opacities, basically. So basically the lungs are going to be filled with all the particles. You will do the X-ray when you get to the X-ray glass. I'm just basically just telling you what you will see, but you will see all these. They are famously demonstrated. Now, treatment usually steroids, okay? Because they're trying to help them on immunosuppressive drugs in some cases, because you will try to reduce the immune reactivity, the immune system reactivity, because the fibrosis and all that is coming as a result of the reaction from the immune system. So you're going to use immunosuppressant, okay? So antifibrotic therapies usually because you want to decrease the amount of fibrosis. Colchicine is a drug we use. Now, that's intrapulmonary. That's the brain. What could be an extra? Extra, either the thoracic cage itself, as we said, or the muscles, either the intercostal muscle, the diaphragm, and so on. Okay? So causes are going to be damage to the rib cage, diaphragm, or the nerves, innervating these structures, preventing lung expansion. So ex factum, that's victus ex factum, basically when you have a depression of the thoracic cage, okay? So the thoracic cage is not the normal size, and it depressed to the inside, inwards. Now, obesity can do it to some extent, basically because you have tremendous amount of pressure on the chest wall, preventing it from expanding, right? Pleural effusion, if you have fluid between the pleura, between the visceral pleura and the parietal pleura, that's not allowing for the lung to expand, right? Oh, myasthenia gravis. Myasthenia gravis, you probably want to talk about myasthenia gravis at some point. Basically, somebody who has a nerve firing issue. So the nerve is not firing to get the diaphragm to contract, right? That's myasthenia gravis. Basically something, or fast destruction of acetylcholine. Remember, your neurotransmitter is acetylcholine, right? So if there are certain people who suffer from certain disease like myasthenia gravis, they have certain enzymes that are destroying acetylcholine prematurely. And as a result, that neurotransmitter is not allowing for the muscle to contract, okay? It's going to be your myasthenia gravis. So basically impaired diaphragm movement due to the neuromuscular junction destruction, right? So, or the larger group is going to be the idiopathic. So idiopathic restrictive. You can see it as IRLD or ILD. Basically, you are talking about idiopathic lung diseases. Usually, these are the undefined, so the cause, we don't know what is causing it. Okay? Now, the symptoms are usually cough and progressive worsening and shortness of breath, depending on how advanced pneumoconiosis in these cases or the deformities to the outside of the lungs are. Difficulty breathing due to reduced lung expansion. Okay? The effect of the lung function are listed here. Remember, you have a decreased TLC, decreased FVC, the vital capacity, the forced vital capacity, and decrease their FEV1. So your parameters mostly is going to be decreased. The only thing you have to remember is going to be slightly normal or slightly increased, the FEV1 to the FVC. Okay? Fibrotic lungs are stiff, causing difficulty in stretching and expanding properly. Now, complication, of course, hypoxia. So remember, hypoxia, when the tissues are starving for oxygen, that's hypoxia. So pulmonary vasoconstriction. Why would you develop pulmonary vasoconstriction? Remember, anytime you don't have, remember I drew it in the board the other day? Anytime that the lungs are not perfusing correctly, so that's going to make vasoconstriction. If you have a massive vasoconstriction across the entire area of the lungs, that's going to increase the pressure on the right side of the heart. Makes sense? And that's what is known as the pulmonary hypertension, right? It's going to develop pulmonary hypertension. Basically, the hypertension is on the right side of the heart. The right ventricle has to hypertrophy and to start pumping with tremendous amount of force to overcome the resistance in the lung. Okay? So that's pulmonary hypertension. And as a result, you're going to get right ventricular hypertrophy, which is known as the cor pulmonale, right? In severe cases. Management, interstitial disease treatment, like steroids, immunosuppressive drugs, anti-fibrotic, basically anti-fibrosis service. Extrapulmonary disease management depends on the underlying condition. So if there's any deformities could be corrected, then it has to be corrected. Right? Now that's your summary right there. So interstitial lung disease or restrictive lung diseases, fibrosis of the lung tissue reduces the lung capacity and function. Extrapulmonary restrictive lung diseases caused by issues with the chest wall. Is it the diaphragm, the pleura, external intercostal muscles, and so on. Okay? Diagnosis mostly is going to be based on, of course, history. History is revealing. If you are interviewing somebody who worked in coal mining for 30 years, right? So basically, you're having an understanding like what's going on, right? History will give you a lot, but spirometry, imaging, and so on. Okay. So treatment primarily corticosteroids. You have additional other service for fibrosis. Basically, you're trying to give medication that is going to decrease the amount of fibrous connective tissue, right? Now, sarcoidosis, idiopathic pulmonary asbestosis, and all that we just talked about. All right. Main points. Let's go over the main points. Now, idiopathic pulmonary fibrosis characteristic, progressive lung fibrosis, lead to the destruction of the lung architecture. Okay? So fibrosis is leading to the destruction. Typical imaging finding in high resolution CTs are going to show diffuse septal thickening with honeycombing. Okay? I probably have to show you some of those imaging. Basically, it's going to be very classical because fibrosis is going to be picked up by the CT scan. It's going to show very thick lung, right? Now, the common symptoms is going to be your progressive shortness of breath, dyspnea. Okay? So, myofibroblast These are the ones that contribute to the cells for the process of contraction, right? When they are function correctly, right? So they expand, allow for expand of the lung and collapsing of the lung. However, if you have them in tremendous amount of numbers, that's what's going to lead to fibrosis, right? Pulmonary function test finding in idiopathic pulmonary disease or pulmonary fibrosis, you're going to have what? They're going to have decreased their lung, their TLC is going to be decreased. Remember, this is very important. And you're going to have a decrease on the vital vital capacity, right? Forced vital capacity, because they have difficulty breathing in, right? Primary affected lung structure, fibrosis, is going to be your primarily, basically you have fibrosis in the alveolar interstitium, okay? Environmental exposure, high humidity is not typically associated with, so basically the exposure that you will see in the questions is going to be silicosis, yeah? Or silica basically, causing silicosis, or coal dust, pneumoconiosis, or other like asbestosis and so on. But environment, humidity is not one of them. Dyspnea, so occurs due to alveolar collapse and decreased lung compliance. Now, some people do have genetic mutation in these genes, the TRT and the TRC genes mutation. Usually, these are the ones that they have familiar fibrosis, basically running in their families as a result of the formation of these. Diagnosis is going to be using CT scan and pulmonary function test. Okay? Now, why do you have hypoxia? You have hypoxia because you are not allowing for the lung to fill, expand and fill with oxygen. Makes sense? Eventually, what you're going to have hypoxemia, right? So they are connected. So hypoxemia, when you have emia, is blood. Remember, emia is blood, right? Emia is blood. So hypoxemia, basically the oxygen capacity of the blood being reduced, that's hypoxemia. Eventually, hypoxemia is going to lead to hypoxia because you don't have oxygen delivered to the tissue. Now, inspiratory crackles, usually because when the lungs open up, when you try to force breathing in, and you have a fibrous connective tissue, when this unit open during inspiration is going to cause what is known as inspiratory crackles. Okay? Uncommon finding, unlike chronic bronchitis in fibrosis, does not typically present with a productive cough. That's very classical differentiation between obstructive and restrictive. They don't have chronic cough. They don't have that amount of mucus secretion, right? So that's, yeah. Because again, remember you have lungs that have been converted to fibrous connective tissue, right? Fibrosis. Effect on the lung elasticity is going to decrease the lung elasticity. Okay. Now this is called the histopathologic hallmark of interstitial pulmonary fibrosis, the honeycomb. So you have the shape, they look like a honeycomb, and that's why they call it the honeycomb cyst. Defining, under the microscope, you will be able to see them very easily. Chronic cough is going, usually if there is chronic cough, it's going to be dry. It's going to be non-productive, okay? And usually it's resisting to treatment, because what is causing the cough with this group of pneumoconiosis is the irritation. So you have these particles, and they are irritating not because you have mucus that you want to secrete. That's in chronic bronchitis. Here, because you have these dust particles irritating the lungs and calling for the cough reflex. Okay? And usually that's going to be dry. Okay? The resistance of myofibroblast, because myofibroblast, as a result of the irritation and the inflammation in the area, are going to cause a multiplication of their numbers, and that's going to lead to fibrosis. The risk factor, smoking is a significant risk factor to when it's combined with other occupational factors, right? Compliance, the non-compliance is going to be reduced. Very classical for if you this set of diseases, your lung compliance is going to be reduced. Okay, that's it. All right, we have 5 minutes actually left. Tomorrow we're going to expand more. Tomorrow I'm going to go back and start reviewing. We're going to start reviewing. We'll watch a couple of presentations, and I will be happy to show you anything you want to see in the visible body for cardiovascular or respiratory. So we have tomorrow, so week 8. So we are way ahead of the game. So we're going to start reviewing. Do not wait, okay? So basically what you want to do, you want to go, all of the quizzes are open, okay? Even the one that we did a long time ago before the midterm. Your task is to practice, practice, practice. The more you practice, you're going to nail the final. Go ahead.
So is the final more cumulative or is it mostly?
The final is cumulative. So you're going to have questions from the first day of class. Okay? And that's why we want to review. So we have week 8, 9, and 10. We have 3 weeks, guys. We can start this game from the beginning now. Yeah? So we'll use this time very efficiently, right? We'll use tomorrow from 7 o'clock, we're going to start reviewing, we're going to go back. So basically first I'm going to start the respiratory system one more time from the start to finish, which basically is not that much, right? And then we can go back, we can reverse. We're going to go to valvular diseases, we can go to pericarditis, anything that after the midterm. Now, time allowing, we can also start stuff before the midterm. We have plenty of time. So if you listen to me and if you come here prepared and you engage and we talk and all that, when you go home, you don't have to touch this material. We will do it just here. Yeah. I will give you, the schedule is still not out, but as soon as the schedule is out, so supposedly either this week or next week for the finals, I will, more than likely is going to be here, so you don't have any mastery center or anything to worry about. Go ahead. They're still working on the finalizing, but I think it's around that, because I have pathology in the morning, and then your class comes after, so around 11, I think. Yeah, it's posted. Yeah, but yeah, just wait on that. But because until they say, "Oh, this is the final, no more modification," usually I try not to give you the final word, and they didn't send that yet. But as soon as, so it's still in the, because there are some other instructors, there are some conflicts with the classrooms and all that. As soon as that is resolved, hopefully by next week, we will know for sure. But yeah, but more than likely it's around 11. Any other questions?